Good evening. We started from good morning to now good evening. Till good night we'll be together. Uh, we know we are late, but this is an important topic because we have a very esteemed panelist. Dr. Surinath has traveled all the way from Hyderabad. Uh, Dr. Rakesh Bhatia, sir, he has traveled all the way from Agra. And our own, the master blaster of the vaccinology and infectious disease, Dr. Abhay. So the topic is important. See, name, just look at the names because then you will understand what I am going to ask them. It's a common confusions, controversies, and consensus. So I am going to put forward all the confusions and controversies. So you may not have the correct answer. You feel it is correct, or they may not reach to consensus. But definitely these are the questions which are daily we are facing in our day-to-day practice, and that's why I am putting in that way. So it may be some controversial as well as the confusion creating program questions. So I would like to start from Dr. Surendranath, Hyderabad Express. So influenza, yes, we had a talk from Dr. Pramod Jog that he said it has to be given uh, first 2 doses, first time when we are giving, then at monthly interval, then you give annually. Now, few questions. What is a waning period? By which time you think that the antibodies they wane? So there are some thought that it wanes very fast. So whether to give annually or biannually, because sometimes vaccine strain changes, and when you are at the end of the season, you get another vaccine which is having a different strain. So whether to give it every 6 monthly or annually, that is one question. And I will be asking the all question. You can then complete with this. Okay, fine. You just first go for the annual or biannual.
As far as the flu vaccine is concerned, at present recommendation is to give a single dose annually. If you are starting at 6 months of age, the initially you have to give 2 doses with 4 weeks gap. After that till 9 years, as far as the ACVAP is concerned, till 5 years annually only 1 dose is recommended. So there is no question of giving 2 doses in a same year. It doesn't arise because the recommendation is not there to give 2 doses
So
in 1 year.
practically, sir, how long the immunity lasts once you give the vaccine, and what is the effectiveness of vaccine?
What the evidence shows is that after 7 months there will be definite waning of immunity is there, definitely. I mean, you may not have enough antibodies to protect against the virus.
So can I go for say every 6 months if I can afford to get to avoid that flu?
Presently, the recommendation of CDC is also to give only 1 dose. Till the recommendation comes, we cannot give 2 doses.
Suppose, sir, I am giving every 6 monthly. What is harm? Yeah, definitely out of the guideline. But is there any say hyper-responsiveness or something like that?
Definitely, I mean, effectiveness of flu vaccine it is not as expected as it should be because it is only between 50 to 60% most of the times it is matching with the strains which are existing in the community.
Dr. Bhatia.
So original sin, the concept of original sin is there. So what you see is if you give an antigen, if you repeatedly give the same antigen, your immune response may not be so good. That is one thing. That is especially with the flu vaccine, this has been reported.
So then again my question is, we have been ACVIP has recommended to give it up to 5 years. Okay, after that there is no recommendation, but most of us are giving every year, a year and after year vaccine of flu. So
absolutely, there is no problem. Every year it can be
so
given
then
even after 5 years. There is no problem. Definitely we can give this vaccine.
So then what about the hyper-responsiveness? Dr. Bhatia, you would like to add something?
See, the primary aim in giving the flu vaccine is to cover the active flu season. So there's no point in giving it twice a year because most of the part of the country have different defined seasons of the flu infection. So when you want to have a pre-monsoon coverage, it covers you for 6 months. And by the time the vaccine's effectiveness goes down, your season is already covered. So giving 6 months is not recommended. That's why you have annual vaccination with flu. Unfortunately, flu is one of the most weak vaccines in our armamentarium against diseases. Its effectiveness may be anything between 20% to 70%. And most of the time, it's usually around 40 to 50%. So don't expect too much from your flu vaccine. And our aim is to cover the season. So give it at a time when you want the maximum possible effect from the vaccine. For instance, in the northern part of the country, it's usually in the winters that you have the flu season. So give it before the onset of the flu season. Where it is mostly in the monsoons or post monsoon, the flu season is there. Give it before the onset of the monsoon, let's say in June or July.
Wait, you can add few points if you like to, but one question to you. It happens, we usually give the vaccine every May, June because the southern hemisphere vaccine comes in April, May. What happens by the time you give it, it comes to September, October, you see that the patients are coming, maybe annual vaccination, and the new vaccine, northern hemisphere has come. Now the question, two questions. Suppose I have not given the vaccine that year, what should I do? And if I have given a southern hemisphere vaccine and at that time both are available, what should I choose?
So it all hello. Yeah. So it all depends in which area are you living. Number one, because though India is in the northern hemisphere, most of the part of India behaves as a flu active as a southern hemisphere. The only exception to, as rightly mentioned, that in the northern part, where will your winter peak, and in that case, really, of course, I will go for the new northern strain vaccine. And in the other part, I will not wait, but will give the what is latest available to it, and then in the subsequent year, I will take care that you will give the southern strain. Means I will give the next vaccine in the May or the June to cover the rest of this. So it all depends on the geographic area, what is the flu activity, and what is the latest strain which is available.
Now I have given one dose, and when patient is coming for second dose, new vaccine has come. Now I have option of both. What should I do?
I will not give. I will continue with the
Same.
no. I will in the next 1 month. In the next month, I will come with the southern one, May and June, but will not opt for the newer one.
I have given September the southern hemisphere. Patient comes in October. At that time, southern and northern both available.
They are not the definite.
So newer one.
Newer one.
So whatever
Consensus?
vaccine is a new vaccine is available, it should. Really speaking, if you see the difference
It is a
between
very short interval. I would say what you are telling is very short.
But
It
sir,
comes- most
it
of
comes
them it
nowadays.
comes
I don't know. The vaccines come so early because initially we used to wait for May and June.
Dr.
Now April we get a new vaccine. Say southern hemisphere.
Chetan, there is one more thing. When you see a tetravalent vaccine, compare it to the northern and southern hemisphere, the three strains are same. Only the one strain is different. That is H1N1 is different. If the circulating strains are different, sometimes northern hemisphere, southern hemisphere strains will be the same. So what happens is practically, even if you give a NH or SH vaccine, only one strain is different. All the three strains are same for the both the vaccines. You have to take this into consideration. I don't think we should not discuss much about it. Whatever the vaccine is available when the patient comes, give it.
So the consensus is we will be using whatever the latest. Okay, fine. Now meningococcal. I don't know. Basically, now in practitioners, we know that we have the two vaccines available. One is available which has been recommended and DCGI approved to be used less than 2 years. We know that it's Manactra. So we have to start at 9 months and then 12 months second dose. And another vaccine, Manvio, which has been DCGI approved to be given after 2 years. Now that Manvio out of India has been, can be given less than 2 years also. Now the question is, people they think that because it is not been recommended less than 2 years, so they wait till 2 years and then they give the single dose of whatever vaccine to just cut down the cost. How sensible is to do it?
Yeah. So if you look at the incidence of meningococcal India in our setup, there are very few pockets are there where the disease is endemic. And when we talk of an endemic meningococcal disease, the main target group is in the infancy. So ideally, as a requirement of that particular spot, the vaccine is to be given in the infancy and not after the age of 2 years, number one. Second, this is a disease which is the shortest of the short incubation period. And therefore, these are the candidate or this is a vaccine where the booster is a must. So because the trials are done after the 2 years in our country, we recommend as per the product insert that is only 2 years. I think it's a waste of the resource. It's a waste of the resource. So it's a vaccine which is meant for the endemic area for a particular risk And that too, with the caveat that you are going to give the booster dose. So that is the ideal situation.
Very well said. Very well said. That the things are very clear. Now, Dr. Rakesh Bhatia sir, mumps. I think I heard that Agra had a very big, period when there was an outbreak sort of thing. Even in Gujarat also, we have seen plenty of mumps cases in recent past 4-5 months. So, suppose a 3-year-old child who has suffered from mumps, after that, do we need to suppose patient has come at 3 years and he has received the MR vaccine campaign. He has not received any MMR. Now, do we need to? It's very clear, mumps is there. Do we need to give the vaccine at 4 to 6 years?
See, right now, the entire country is in the grip of mumps outbreak or epidemic, whatever you may call it, whether it's from the western part of the country, from Bombay, from Vadodara, or from the northern part of the country. All of us are suffering from the mumps epidemic right now. The debatable part is whether it's because of the use of the MR vaccine in the government-induced schedules and the missing of the mumps vaccine. Now, this particular child who's 3 years old and has already suffered from mumps. Now, mumps gives you lifelong immunity. So, the MMR vaccine, whether it was given or not, doesn't matter for this particular child because he has already had the mumps. The other two components are the measles and the rubella. Now, as far as the MMR vaccine is concerned, rubella gives you excellent immunity even after one single dose, up to the tune of 97%. For measles also, the immunity given by MMR vaccine is excellent. And if a child who's 3-year-old and assuming that he has received both the doses of the MMR vaccine as recommended at the age of 9 months and the 15 months, he is practically immune from measles. Still, 2 to 3% patients, 2 to 3% children will still be able to acquire measles despite 2 doses of the MMR vaccine. For that particular purpose, MMR vaccine should be given to this child. As far as rubella is concerned, again, excellent response to even a single dose for protection against rubella disease. So, from the point of view of the rubella and from the point of view of the mumps, we don't need MMR for this particular patient because he has already, assuming, received 2 doses of the MMR vaccine. And mumps infection is that he is not likely to have it again. So, for purposes of mumps, MMR is useless. For the purpose of rubella also is practically not required. Only from the point of view of the measles protection, which may sometimes occur in at least 3 to 4% cases, he may need the MMR vaccine. So I will recommend that at 4 to 6 years, give him MMR again.
Correct. Now the question is role of post-exposure prophylaxis if the in family one sib is having mumps. Do we advocate it for mumps? I am asking. Measles, it has been very clear that you have to give it within 3
It is
days.
always, our Indian schedule is confusing because we are giving MMR 3 doses, 9, 15 months and 5th year. Whereas if you see the AC schedule, that is CDC schedule, they give MMR 1 dose at 15 months and finish off second dose at 4 to 6 years. Why I am telling is, in the present scenario where our country is going through a epidemic or outbreak like situation, most of our children who have received only MR. So I think a proactive measure is to give as an outbreak response MMR vaccine to all those who have received the MR vaccine. That's what, I mean, even the US also does the same thing. Whenever there is an outbreak, they do give MMR
I am
vaccine.
asking for post-exposure prophylaxis, the other sib. He has not received the MMR vaccine. He has received the MR vaccine.
That's what I am telling.
So,
It is like outbreak response.
So, like chickenpox, like measles, mumps vaccine has no role as far as the post-exposure prophylaxis.
Yes, sir.
This should be very loud and clear. So, mumps vaccine in a contact, close contact, is not going to help. But suppose if the same child is living in a colony or in a hostel, or if there is some outbreak situation in that particular area, and in that case, the person or index case has been exposed, there is a definite role, irrespective of the prior infection or the immune level against the mumps. So it is very clear that for post-exposure prophylaxis, in an isolated context, there is no role of post-exposure prophylaxis unless there is some quantum of cases in a particular area or a particular group where it is indicated.
So not at the individual level, but at the community level,
Yes.
it will be recommended.
Okay. Now, the situation is now, we know that in practice we are getting the patients, because now with a very good vaccination coverage and good efforts of government, there is a good facility of National Immunization Schedule, NIP. Patients and parents, they have been going for primary vaccination to the government, and then many times they have some complication, or just like that after 6 months they come back to us. So this is routine scenario. I think now majority of us have started vaccinating at 6 months only. We start with the flu because primary vaccination is over. So patient is coming to me for 6 months flu. I given 7 months flu. Now patient is coming at 9 months. Now at 9 months, there is, you know that in government we are giving 6 months and 6 weeks and 14 weeks. They give pneumococcal fractional IPV, okay, and with pentavalent vaccine. At 9 months, if patient comes to me, shall I send him back to the government setup, or I can give the PCV, because PCV also they are giving 2+1. See, if I give one PCV, same brand which government is using, I am completing the schedule. So is it okay? Because I can give measles.
We understood the point.
Okay.
So,
So
may
this
I-
is a routine day-to-day issues.
Yeah.
you tell your points up, then I'll tell my.
Yeah, so now I think whenever there is a two priming dose is there, and if the 6 months has passed for the last dose, you can give the third dose as early as possible as a 9 months. So there is no harm scientifically. But as a routine, we'll take care of the 1.5 year. But here, two doses have been completed. If the parents want, if the 6 months is there with the last dose, I will definitely give it 9 months.
Dr. Ramnath, Chandra,
Yeah. There is one thing. At 9 months, government is also giving JE vaccine, which we are not giving at our clinic.
which one?
JE vaccine in some areas.
See, okay.
In some
He
areas.
is right in certain.
No. If JE vaccine is given in your area, tell the patient to go to the government and take it. Suppose JE is not given, if he comes to my clinic at 9 months, I will definitely give PCV and an intramuscular IPV also along with MMR. That will complete like a government schedule, and there is no need to repeat PCV at 15 months.
Okay, now the life is not that simple. Now it is becoming difficult, because now we are not going to have a standalone IPV from next month. Now what? Yes. What will you do? Back to square. Because initially we were having that armament in IPV in our armament.
This is,
Come to us.
this is a different situation. IPV standalone.
So there is a scientific explanation of that. Child has already been given 2 doses of fractional IPV. Third dose is a fractional IPV at 9 months. Government is going to give it. So, as far as IPV is not available in your case, I will definitely send it to the government for the fractional IPV. That is where I will not like to miss. I may miss even PCV, but I would not like to miss the fractional IPV. It's a very important tool for the individual child, for the mitigation of the risk and type polio. But at the same time, if the patient says, no, I will not go to then I will call him that make sure that he comes to you at 15 months or 18 months for the tetrixam combination vaccine which contains IPV. Which contains IPV.
There one more thing. I mean, if the child has received at 3.5 months third dose of DPT, there is no harm in giving a fourth dose, a booster dose after 9 months. You can give a hexavalent vaccine at that time to that child.
The standard recommendation is you should have a gap of 6 months.
6 months, yeah.
From the last dose of DPT containing vaccine to make it a booster dose. So that is one option.
One option is that, but I will also
But, yeah.
like to look into the consideration about the pertussis component as well. See, 9 months is too early for the pertussis or booster is concerned. So if you are looking at the fractional IPV or PCV, yes, you can give 9 months, but as a whole, there is no harm in waiting for another 4 or 6 months and to give 1.5 year booster dose in the form of combination containing IPV.
We can give it at 15 months earliest, right?
Earliest is 15 months.
So
That will be
isn't it a very tricky situation? This is really confusing situation. Anyways, now the one more thing, rota. Suppose he has received 2 rota and he comes at around 9 months. Our guidelines or ICVP says not after 8 months. What should I do? In government, if they will go, they will give it till 1 year of age. So what should I do? Suppose he comes at 11 months and he has not received 1 rota.
So I will do 2 things. If at all I want to use in the private, I will ask in a written consent, because the Rotasil product insert says that you can give till the age of 1 year. So I will make sure that I am safe giving it. But the ideal thing is to send him to the government sector where they give till the age of 1 year.
So again, there's a problem. Anyways, I'm trying to catch hold of the patient. Abhay bhi ke jane do, jane do.
No, but what will you do then?
I'm asking, sir.
No.
I'll follow by tomorrow.
No, I will not.
From
I will-
tomorrow.
so
There is one
I
thing
will
where-
not give beyond the age of 8 months. That is very, very clear, 32 weeks. But if,
Okay, now this
if
brings
the
me.
patient does not want to go to the government sector, I will make him to return consent and I can give the Rotasil because the product insert says that it can be given till the age of 1 year.
I think there
I
is
have
some.
a point, I have a point, Chetan. Sir, you are in ACVIP.
Boss.
Was.
You are, let us say, if you are in ACVIP now, we have enough data showing that Rotavac, which is given in
Yes,
the
I am
National
coming to that
Immunization
point.
Program, till 1 year they are giving as a catch-up vaccination. We did not have any increased incidence of the intersusception in the community. Even the Rotasil product insert says that it can be given up to 1 year. So why ACVIP is not just recommending whatever CDC is recommending?
Now
Can
we
we
have
take
a
our own
data.
data and recommend that it
These
can be given?
recommendations are going to be dynamic. It may change, but
Correct.
as of now, there is no recommendation.
But there is a point in Dr. Surendra's viewpoint is there is a data because now they have given n number of rotavirus vaccine till 1 year of age in government sector. There is no increased incidence of
That's why I
interception.
said I will give, but with a return consent that we are ready to accept it.
So again, this is a tricky situation, and you can find your own way. Yeah, Gopabandhu.
They have data.
They have data, and even now, retrospective data is there. Okay.
No, see, ACVIP mainly takes into consideration private practice and where the every child is very, very important. And the first dictum is that do not harm the normal, healthy child. So even for one case end up in the intersusception, it will be a lifetime stigma to a personal carrier. That is very important. Whereas government is looking at the in general and they ask for the larger coverage and that is why the age limit is there. I am asking you that question. No, this is something deviation from the what is routinely done. That's why consent.
Anyways, this is a controversial situation, confusing situation. We may not get the consensus. Maybe in years to come, we will get some consensus. Thank you so much for that wonderful discussion.
That fear of intercession is gradually going away.
Yes.
There was a time it was paramount to think of interception when you're giving the Rota vaccine. But over the year, the vaccine has shown a fairly good track record and interception fears are gradually going away. And sooner or later, the schedules will change. WHO recommends till 2 years of age.
Yes.
So that one must remember, that is your backup when the consent is taken. The WHO recommends Rota vaccine till the age of 2 years. The government India recommends
Yes.
till the age of 1 year. So there's no
Anyway,
worry about the
so
legal
let us go to the next topic. That's the co-administration. Suppose, sir, patient comes after say 4 years, 5 years, not received any vaccines, and they are ready to take the vaccine because they have to travel abroad, and now they are suddenly remembering that they have to finish the vaccination schedule. So my question first is, how many vaccines can be given at together? Which two vaccines you would not like? What is simultaneous administration? So, which two vaccines I'll be giving on the same day, and what is the simultaneous administration?
We can give n number of antigen on a single session. That is the
1, 2, 3, 4, 5.
There are only few exceptions are there.
So that's what I will ask. Which two vaccine which we would not give together? Because whenever the patient comes with
I will not give PCV 13 and your polysaccharide vaccine simultaneously. I will not give PCV 13 and Menactra simultaneously. I will not give yellow fever and MMR simultaneously.
yellow fever and MMR not together, PCV 13 and PPSV 23 not together,
And PCV 13 and Menactra.
and PCV 13 and Menactra. You can give Menvio together.
Your
Okay.
question related to yellow fever and MMR, but I have added two.
Pardon?
You are aiming for a yellow fever and MMR, but other two is also there.
Yeah,
Which are more practical.
My aim is different, sir. The situation is, many of people are still believing that BCG and MMR cannot be given together.
It can be given.
They can be given.
So BCG and MMR can be given together. That should be very clear. So that is one thing. Now the question is, sir, IM and subcutaneous. Many times we give it we don't think much whether to give this and this. Why by we are talking, you are giving subcutaneous to intramuscular. So is there any harm if few vaccines were given to be any specific thing? This vaccine has to be given IM, otherwise not counted dose.
Hepatitis B and rabies vaccine, never ever, it should be in the intramuscular. And MMR, measles containing vaccine or chicken pox should be given subcutaneously, but if you give it inadvertently, there is no need to repeat it.
HPV,
Yes, HPV also. Yes.
We also.
meningococcal,
Yes, can be given.
any IM only or IM or subcutaneous.
I am only.
I am only.
So,
I'm-
so I think we.
The only thing is about the patients with bleeding disorders, where vaccines which are given generally intramuscularly
Subcutaneous.
should be given subcutaneously.
If they are allowed to be given.
Yeah, if-
Otherwise, you give IM only and press it for a long period of time.
Yes.
It's suppose in patient of hemophilia.
Because that the problem there is because if you're giving subcutaneously, it's practically an off-label use of the vaccine, and in which situation there's not enough data to prove that they are equally effective or they are less effective. But still, on the safer side, and the person with strong bleeding diseases, they can be given subcutaneous.
So
4 vaccines.
here I am going to use the little permissible language. As far as the hepatitis B is concerned and rabies is concerned, I think these are the two vaccines must be repeated. But I am not sure about this HPV and meningococcal
Meningococcal.
vaccine.
HPV,
So
HPV
I am not
is
saying
also.
that you can give it subcutaneously, but I little using a permissible language. But for two, this hepatitis B and rabies, it is intramuscular. Yeah.
I believe that HPV, meningococcal,
It is there, but-
hepatitis B, and rabies. These 4 IM only. Okay, fine. And we discussed that thing. Now, interchangeability. Now we know that whenever we ask about whether we can interchangeably use particular brand, we use standard. When you are pushed to the wall, you can, or if you don't know what has been written, you can use it whatever is available with you, because we don't want to lose the patient, or rather at point of contact we don't want that should not be a missed opportunity. So sir, which vaccine you will never use interchangeably?
HPV is one vaccine which should never be, there should not be any change of the brand. Whatever brand you were using, you must use the same brand.
Gardasil 4 to Gardasil 9.
No. I contradict this one. There is one statement in the Ask the Experts, CDC Ask the Experts, clearly written that HPV also can be interchangeable, it can be given. Absolutely, there is no problem. For the serotypes which are existing in the vaccines. So they don't, in fact, I'll show you the statement. It is clearly written that it can be completed with any brand.
Now I think
No. I mean,
Yeah,
it is written, but preferably you should use the same brand.
no, correct.
I think this with Cervarix is no longer no longer.
Cervarix, forget about it.
Yeah.
Suppose
So-
we have given a Gardasil
Yeah, you can
4.
now you can go for nanovalent. Yeah.
No.
Monovalent.
Okay, now I want to go for Cervarix. There's no data, no?
Not recommended. Or there is no
There's
data.
no data.
So from Gardasil 4 to Gardasil 9, it's yes. But
Yes.
from Gardasil 4 or 9 to Cervarix, there is no data.
There's no data. That's the problem. The same is true about the DPT containing vaccines like Hexaxim or Infenrix-Haxa. The
This one even
interchangeability
PCV also?
may be done. Interchangeability may be done in dire situations when nothing is available. But there is no data to prove that it is equally efficacious. The interchangeability is
So
equally
there are few vaccines where we get the data like Rotatec and
Rotavirus, hepatitis,
Rotarix.
flu, even
Rotatec
flu.
and Rotarix, they have data. Then Prevenar and Synflorix. Synflorix followed by
Prevenar.
once you give Synflorix and then
You
you
can give Prevenar.
Prevenar, you can give it. So there are few data available. Otherwise, we use left and right because we know that when new PCV came in the market, we started using it left and right, whether it can be given or not, and people are using it. And so this is a thing, but this is a point of confusion and controversy. Now, sir, cold chain. We all are practicing pediatricians. So what is the ideal things we should be keeping in our clinic?
So actually, it's appropriate temperature change. So there should not be only a injury or damage only because of the heat or light, but also so there are freeze sensitive. So we have to take care of both the things. There are certain vaccines which are very freeze sensitive, like our hepatitis B, and there are certain vaccines which are heat sensitive, like our polio or our constipated BCG vaccine. So we have to strike the right balance, and the ideal for most of the vaccine, with few exceptions, it is 2 to 8 degrees. So you have to maintain this vaccine 2 to 8 degrees. and therefore you need to have a purpose-built refrigerator. You can use a domestic refrigerator, but you know the domestic refrigerator itself has a freeze. And when the door is closed from the freezer compartment, there are a lot of cold waves are coming, which also decreases the, which can also affect this freeze-sensitive vaccine at the bottom as well. So I think purpose-built freeze is an order of the day.
That is the best, but alternatively you can use a double door fridge, not
Yes.
a
And
single.
frost free also. A double door frost free
Yes.
domestic refrigerator is
can be.
the compromise that you can.
And if with inverter, it is good.
Yeah. But ILR is little.
See, but it is not convenient. But my point is different. I am coming to different point.
Hold over
Now,
time.
sir, you are using a purpose-built refrigerator that is given. See, one thing I would like to just mention over here. You can use purpose-built respirator, this refrigerator, where you have a 2 to 8 degree all throughout, and you have a refrigerator where Dr. Suryanand said it has to be double door. Okay. Now, when I have a purpose-built refrigerator, where should I put my polio drops?
It goes at the bottom.
If I have got 5 polio vials, where will I put in 2 to 8 degree?
And the
Sir,
purpose.
it gets, its VVM gets changed if I am using it 2 to 8 degree.
So
Purposeful refrigerator with a fan will maintain the temperature.
No, 2 to 8 degree, if you practically see, put it your 5 vials, till you use it, they will be, VVM will get expired.
In the purposeful, there is a fan at the top of the compartment that will maintain the temperature at all times.
I am telling you.
What he
So
is telling
refrigerator is showing that 2 to 8, 4 degree because I am using pulverized. Is anyone like, because see, usually OPV has to be kept, if you want to keep it for a long period of time, in the refrigerator, freezer compartment.
If it is for long period, if it is long for a
So
long.
what is the definition long?
whatever polio drop you are using,
Huh.
it is a 2 to 8, but the extra stock will be in the freezer compartment of the other.
Yes. So that, so you
And that
need,
same is for the rotacilla as well as rotacilla. Same thing.
So
whatever
what
you are using to store it 2 to 8, other rest you say the freezer compartment.
So it is reverse in domestic, and the purpose it's reverse. In domestic, the polio goes up, and in the purpose it goes down.
in
purpose
purpose
built
built there is no
no
question
keep
of,
it anywhere.
you can put anywhere. Yeah.
You can.
So in ILR, it is
If you are
front
talking
loading
about
and top loading.
You are talking
It's
ILR.
different. Yeah, right. Okay, fine. And vaccine which don't have VVM, which are those vaccines like?
I think most of the UIP vaccine has the VVM.
Yes. So there, because government's rule is there.
All the vaccines should have now
That is
VVM.
mainly meant for the developing country where they go in the field work and they need to have the longevity. So VVM is the good idea.
And sir, can you just tell me what is the VVM importance, like different VVMs? It is not the same, no?
I do not exaggerate, but there are 30, 14, 7 or 2, and it indicates the time for which the vaccine remains stable at the 37 degree. Means the days, means if it is a VVM 7, the vaccine will remain stable for 7 days at 37 degree.
That is a cumulative exposure.
Cumulative. That is cumulative action, not only the temperature, but
Right.
the time. So the damage of the vaccine is a function of the time and the function of the degree of temperature.
So
So
there
we
are
have-
4 varieties. There are 4 varieties: the VVM2, VVM7, VVM14, and VVM30. So at the end of 2 days, that is VVM2, the vaccine will be useless. At VVM30, at the end of
30 days.
at 37 degree, the vaccine will be useless.
At the end of 2 days, 48 hours of cumulative exposure of the temperature above 37, you will get the VVM lost.
So the practical importance was if you are going for a vacation for 3 or 4 days and suppose your freeze is not working, so you look at this chart, look at the VVM. So all vaccine probably you may not need to throw away. You can use it.
Correct.
It has a positive side also. The-
Yeah, so there is a different open vial policy.
Huh.
There is again the one more important use of VVM is open vial policy with WHO. You can keep the vial for 1 month once you open it.
Right. So now, sir, vaccination errors, they are very common. I think today morning, Yagnesh bhai discussed this BCG given IM. Okay, that's fine, we'll forget it. OPV, by mistake I poured a whole vial into
No
it.
problem.
No problem. I mean, count that dose. Count
No
that dose.
problem.
Should I put in RT and remove it?
No, 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 nothing.
No,
Just
just
There
leave
was,
it.
this is a real incident which has happened. The
Confess the
person
mistake.
called me and then they say, already I did that because it went in.
confess the mistake and reassure them. And it is a valid dose. Count it. It's not it's a non-valid dose.
So there should
Invalid
not be any side effect. Now, suppose patient, I am giving the vaccination, I have given MMR, and suddenly I came to realize, then they said, sir, I had went to Baroda and Satish Bhai gave varicella vaccine. So 15 days only, and we know that there is a dictum that between two live injectable vaccine, so it is MMR, varicella or live hepatitis A vaccine, we should keep a gap of say 1 month or 4 weeks. Now it is less than 4 weeks. We know that one of the dose is not valid. What will you do in this case?
The second one is not valid.
Second one. So when will you give this second dose again?
Second one can be given after 4 weeks of this dose
dose.
of
Or the
the.
wrong date.
Wrong date. So by chance it happens with, suppose we have given a varicella and by mistake you have given some other inactivated vaccine, then that is fine. Okay. So that's not a problem. And most commonly this is I think
There is one more thing. Suppose child has received some blood containing products after getting the live vaccine, within 14 days you have to repeat the dose.
Correct.
So somebody got, by chance somebody was given immunoglobulin, so it is not valid. So
yes, and sir, this is the most common thing which happens in our practice. Most common, I think many of us must have come across this situation. By mistake, we have given a vaccine, which is, we have applied the label on the file and there is an expired vaccine. What should we do?
So again, reassure, confess, don't take the charge of the repeat vaccine. That's the important common sense.
जो ये
and
आप ही है नो,
as far as
जो
expired
दिया है उसका
it's a
वापस
live
करना है
vaccine
पैसा?
or an inactive vaccine.
there is no adverse
If it
event.
is an inactive vaccine, you can give it on the same day or whenever the patient wants, you can give it. But the live vaccine, again, you have to ask the parents to come 28 days after the date.
So we have given the wrong dose, another expired vaccine. Patient is asking for the money refund.
Yeah, you have to
You
give
can-
it free. There is no choice.
So refund the money, give one more dose. If it is a live vaccine which is given after 7 days or 2 days, patient comes, ask him to come after gap of 4 weeks. If it is inactivated, given expired vaccine, you give it right on that day. I think that's
Or any time when the patient wants. suppose दूसरा इंजेक्शन नहीं लेना है तो they can come at their wish.
Right.
Although that's a legal issue, more or less, but the drug or the vaccine doesn't die on that day. It continues to remain active for a significantly long period of time after that also.
It's a
But of course, the government will not protect you, the courts will not protect you. But that vaccine actually is valid. It's not invalid. Suppose it's given within 1 or 2 days or 1 or 2 weeks of the expiry date written on it. After a significantly long period of time, the drug continues to remain active.
so vaccine doesn't become a poison after it crossed the date of expiry, and the date of expiry is the last day of that month which is mentioned. Suppose the IPV which is there, we can use it till 31st of January. So that's important. And by chance you have given overshoot, then see the most common thing what will happen, the person will call you that I have done this mistake. At least see, it can be me, next time it can be you. Just reassure them. If you are in that same surrounding, if the patient comes to you for that explanation, sir, he has given an expired vaccine, reassure them nothing will go wrong. Okay, that's the important, because if that person will say nothing will go wrong, he will not understand, because he is furious about him. And if you are at that position, you just try to help your colleague. Yes, it is an invalidatory administered vaccine. Nothing will go wrong. Something goes wrong, we'll be there to take care of it.
So I think it's our duty as clinician to reassure and give this message that expiry date doesn't mean that the drug becomes a poison or a vaccine becomes a
I
poison.
think we should not give this explanation because we are prolonging the discussion unnecessarily by just telling that it is not expired actually by this date. We are just, we should accept it, that's all, and be very brief and simple.
Sir, they will not
Try to
stop at that
prolong.
point.
They will not.
If we
It is
try
the
to
most common
prolong
cause
the
of troubles.
explanation, it is
Most
going
common
to
cause
work.
of troubles in hospitals and clinics.
It happened with most of us. It happened with me also, especially the flu vaccine. Sometimes we do end up in giving an expired vaccine which we don't realize. MMR was given. I know flu is given, DPT is given. So many times, so many patients came. But only thing is, we tell them, I'll show the even the literature, whatever is there in the book, I'll show them. This is the literature which shows that there is no harm in giving an expired vaccine. There is no harm. Whether it is
In
working or
court of
not, we are
law,
not
something
sure.
goes wrong, then definitely you will be in a
There is no harm.
difficult
Absolutely, you tell
situation.
them that there is no harm. But preferably, what you do is to prevent this mistake.
Now again, it's a discussion.
You will not get impact certificate from Gujarat.
And second thing, sir, then you have to mention the
And
date,
5,000 rupees.
batch, the date of expiry, everything.
All my patient, I am not putting the label. I am telling after 2 years, your label show that vaccine is expired. One thing I also come across that whatever immunization card they have taken to the for the visa, they have not accepted it. They told that these vaccines are expired because suppose 2 years expired. After that, that is an expired. So they
But that too, when we are giving a vaccination, at that time date of expiry is important, not that after when you see.
who will tell the visa people? They are
No,
telling.
no.
That is not a science. That is not a science. वो सर वो तो ऐसा हुआ गया मेडिक्लेम वाले बोलते हैं कि मैंने बोला कि ये टाइफाइड फीवर का पेशेंट बोला कि यहाँ कहाँ लिखा है टाइफाइड तो मैंने बोला कल्चर में लिखा है तो बोले वहाँ तो साल्मोनेला टाइफाइड लिखा है अब सो वी कांट एक्सप्लेन देम
Avoid such things to happen. All this is right, but how we can avoid? I will quote the example of Dr. Kunal. He has a software where he has barcode on each and every vaccine, where he scans the vaccine before using the vaccine. So if the vaccine is expired, it will come as red on the screen. So it is not allowed to generate a vaccine session or a receipt. So we all should be using some digital software wherein all these things are taken care of. How to prevent this?
but I think if he is that particular he is using the scan we can be at least particular to look at the date of expiry.
You can have. Exactly.
It's good that he's using. Yeah.
No, no, whatever, but we can have.
Yeah,
I agree.
I think I respect the time, and I think we had a fruitful discussion. Thank you so much for all of you to be here at this late. Thank you so much, panelists. It was really a controversial, confusing situation. You tried to reach at the consensus with a proper scientific background. Thank you so much, the chairpersons. Thank you all.